everyone. I'm Director of eHealth in Northern Ireland. Northern Ireland has a single public health delivery system, so I'm a part of that single public health delivery system. I'm going to talk a little bit today about our history in using information to inform service improvement, how we've moved that on in the course of the past year to improve information at the point of care, and what our ambitions are for the medium to longer term to use all of that information that we've now gathered to help us design better health and social care systems, and to look at other ways to use the quality of the information we have to improve how the system responds over time, including potential examples moving us into the area of mobile support for self-care. There are just a couple of slides here. Apparently, because I'm free, there's 2 slides, so most of what you see here I'm going to attempt to describe it with 2 slides. We've been collecting system data within Northern Ireland now for a little more than 4 years. So we have single data warehouses where all of the clinical event histories for the population of Northern Ireland are gathered together in a single place. They're accessed directly from the basic clinical information systems, and for a long time we've been using that information to try and drive service improvement. So that information is made available to all of the various clinical teams, right down to individual physician level, back up into specialty teams, mostly hospital oriented, although in some areas we've begun to move that into community settings as well. Team performance is tracked and regional performance is tracked. And we think we can link that, for example, to dramatic reductions in MRSA infection rates, Clostridium difficile infection rates. We publish our mortality data, again sourced directly from those information systems. We have had a major push on reducing the level of waiting for both emergency care and elective care, planned care, and that's worked really well for us. So we believe the process of gathering together very robust information, it isn't gathered by the individual organisations, it's gathered once for Northern Ireland, drawn directly from those clinical information systems, so it's robust, it's reliable, and we can share it transparently, and everyone knows they're looking at similarly derived information which is comparable right across the system. In the course of the past year, we've moved to an electronic care record. I hope you can see that on the screen. So for 2 years now, we've been working on a health information exchange, which is a way of taking all of that information that we have available and exposing it in a single clinical portal, a single view. So it's a kind of a read-only view at this point. So we haven't tried to re-engineer all of the individual clinical systems across Northern Ireland. We think the examples that we've seen of attempts to do that on a large scale show that it's prone to failure, so that's not the approach we've adopted. So this is a clinical portal where all of the information is pulled from the basic individual systems and then is made available for every citizen in Northern Ireland to every health and social care professional. So every professional can access this information and we have the record for every citizen. The core of this we worked on from about 5 years ago, and that's about identifying each citizen uniquely. So we've had processes in place which uniquely identify each citizen. We're a small health and social care economy, 1.8 million people in Northern Ireland. And for that reason we haven't felt it necessary to go down the identity card route. We don't rule that out for the future, but for now that's not, it hasn't been necessary. So we're very pleased with this electronic care record. It's having an immediate impact on length of stay. It's reducing blood tests, it's reducing X-ray imaging because people can access the previous image or blood test. We already have fully computerised radiology right across Northern Ireland, so this has allowed everyone to get access to that and reduce the need for repeat tests, and it improves information at the point of care. Our core interest, and the thing that we'd be interested to talk to others about, is how we use all of that data that we've got, which is producing better performance, producing better individual clinical decisions, to take it on to the next stage and both support citizens to better self-care, and that's where the health element comes into it from our perspective, and also for us as a system to use that information intelligently to design better systems, not only to get better individual decisions, but to design better systems and to understand, for example, whether diabetes care in the west of Northern Ireland needs to learn from diabetes care in the east of Northern Ireland. We've begun to do some of that, and we think we can harness the information to do that more effectively because we've got excellent information across all of those systems from our history of trawling that information and pulling it into one place. So interested to talk to people who have travelled further down the journey than we have, and we have I know some colleagues are here from Olu, and we're interested to talk to them about their self-care, and interested to talk to companies who can demonstrate they have a track record of supporting health and social care economies to make that transition from better point of care to better system design. Okay, thank you.